Thank you very much for inviting me to come to this conference. Now, I told Jonathan it's very tough to give this talk in 30 minutes, but he was so merciless, no more, a couple of minutes they were not allowed. So it's kind of irrational for me actually to agree to give this talk. Fortunately, he didn't ask me to put everything in 140 characters as our presidents do, so maybe I'll give a little bit more nuanced way than in 140 characters possibly about the entire topic. Benjamin and Ross actually introduced some topics, so hopefully I will be able to kind of build on that and go fast over some concepts. So without further ado, we just kind of start with the things that are so obvious to us that have been really promoted in the literature, in a lay press all over the, I think, the world now, certainly in North America. What we do in healthcare is not satisfactory. Estimates are from different countries, but this is one typically based on US data, that we actually spend about 30% what we do is inappropriate or wasteful. At the same time, we don't really deliver up to 55% of intervention we're supposed to deliver, we are not delivering. Some estimates, some modeling suggest that personal decisions are leading cause of death, and that 80% of what we do, all our healthcare expenditures are affected by decisions of you and me and people in healthcare. So obvious question is, are these decisions rational? And which begs the question, what's the rational decision making, which actually builds, I think, on the previous talk and about the judgment and inferences. So if I get interrupted and don't finish the talk, we recently actually discussed many of these issues in this paper, which is now on the in press, and what today I'm just giving implication for overtreatment, undertreatment. But the fundamental message of the day is that what's the rational behavior under one rationality theory may be irrational under other theories. So to begin with, there are many, many theories of rationality decision-making. Actually, nobody knows how many. And in this paper, we try to list everything we knew about, but I'm sure that we missed some. So the key is that which theory we choose to operate under, including actually what to do with that Ms. Scott, is important because it determines our individual decision or a different context, obviously policy decisions. Benjamin already introduced concept of is versus ought. I'll get back to this. I'm not going to spend more time, but typically the fundamental question is what we ought to be doing based on some kind of a normative principle is often different what we actually end up doing, which is the really descriptive theories are dealing with. So as we review the literature and try to go through all of this so-called great rationality debate in philosophy, economics, and psychology, we came up with these 5 ingredients, or even principles, that we think kind of goes or cuts across many theoretical constructs, and certainly applicable to medicine. So principle or ingredient number 1, all major theory of choice agree that rational decision-making requires integration of gains or benefit and losses or harms in order to fulfill our goals. And that's the really key. The goals in medicine is simple, better health, although we can ask our question, what would be the goals for Ms. Scott? Ingredient number 2 is, this typically really is, as Ross already nicely put it, that happens under conditional uncertainty. So what are the rational approach? The rational approach would require some kind of reliable evidence to deal with in these inherent uncertainties. Now, rationality ultimately has to really reflect how we think, what happens in our brains. So we think rational thinking should reflect human cognitive architecture. What we do depends, as already mentioned in a previous talk, on the context. And the context is a key. It should respect all these epistemological, environmental, and computational constraints that our brain faces. And finally, we can't really dispense with ethics. Rationality in medicine is closely linked to ethics and morality of action. So I'll try to kind of illustrate all of these ingredients and principles as we go along. Now, evidence-based medicine has been introduced. Everybody believes, in the last 25 years, has become really just the probably major framework the way we practice medicine and put actually medicine one way or another a solid scientific basis. According to evidence-based medicine, ABM rationality really posits this link between rationality believing was true. In other words, in this hierarchy of quality evidence, it's more rational to believe higher quality evidence than low quality evidence, and therefore actions are more justifiable if they are closer to what represented true, where our estimates are better calibrated. Important point, will I come back later, that evidence is necessary but not sufficient for decision making. We always have to understand difference between inferences and difference between action and decision. Evidence exists on this continuum of credibility while decision making is categorical. What are we going to do with Ms. Scott? We are going to send her to a nursing home or not? So there is some evidence that that is true. For example, we've done some studies, and I'm actually currently involved in that the guidelines panel issued the stronger. So there is a link between quality of evidence and the probability that guidelines panel will issue a strong recommendation. So which would really reflect that ABM principle, that there is the kind of a link between rationality and quality of evidence as it's shown in this slide. But this slide then contradicts what I just said. There's empirical evidence, on the other hand, that, for example, in more than 460 or whatever recommendation that Paul Alexander and a bunch of us actually participated in this study, looked actually at 116 WHO guidelines, and they found that 55%, more than 55% of these strong recommendations were based on very low quality evidence, which just contradicted the first ABM principle. So you can see here how you can go to overuse, underuse, depending on within the same rationality framework. Now, one theory that can actually explain this is argumentative theory of reasoning, which I think is also relevant to the previous question: can we formalize our ideas about judgment? According to Mercier-Sperber, which actually proposed this theory, all our inferences are intuitive. And then they exist on a continuum from unconscious to fully conscious, that would be these explicit reasoning skills. But our inferences are necessarily all intuitive. And according to argumentative theory of reasoning, the reasons people find reasons to support their choices, but these reasons are not necessarily given to favor the best decision or decision to satisfy some criteria of rationality, but decisions are mostly socially acceptable. So our rationality is really proposed just to justify ourselves to ourselves and actually to others. And the theory proposes the reason rational thinking has evolutionarily evolved with the primary social function to justify ourselves and convince others to be believed and gain their trust. And when we look at all these WHO reasons for why these WHO panels moved away from the principle of UBM, all kind of social reason, feasibility, acceptance were given, basically, would support argumentative theory of reasoning. Now, that was the first normative theory. I didn't really give you the list of all of these theories in the interest of time. Second normative theory that dominates today's medical field is decision analytical. This is so expected utility, or rather decision analysis that often is performed to optimize the type of the choices we make and propose them in a guidelines. And this is the classical simple decision tree. Many of you have seen those or maybe participated or have done that. An idea is we use certain mathematical principle. Here is the key, is the principle of expected utility to derive the best possible action in this particular cartoon, showing whether we should choose one treatment or no treatment. And again, key here, there's a based on expected utility, and as you know, remember, expected utility is really just weighted average. Average of all possible results are weighted by their corresponding probabilities. Most important point here is expected utility. There are many, many theories of rationality, and this is the only theory that satisfies mathematical axiom rationality. And as Benjamin already alluded, or has been very widely documented, we violate expected utility all the time. So it's the only theory that meets those certain rationality criteria, yet humans actually violate all the time. But according to expected utility or this formal process of rationality, rationality is a choice is matter of process of choosing, not what's chosen. Good decision can result in bad outcome. A bad decision can result in good outcome. Which, if this is correct, that in the U.S. certainly, and probably in other countries, there's a huge movement now that pay doctors for quality of care. According to that, we should pay doctors according to outcomes. This is immediately telling you this irrational, actually, policy, because doctors can't control outcomes. So and this is probably most important, the slide of the day. One of the important derivation of expected utility model is so-called threshold model. And according to threshold model, our action should occur when there is some probability when we face, for example, patients with unknown or uncertain diagnosis or outcome. There's some probability at which we are indifferent whether to act. And we should act with benefit outweigh harms for this particular probability. For example, this is one of the systematic review about assessing benefit and harms of treatment in somebody with a blood clot in the lungs. Assess that benefit of giving anticoagulant, these blood thinners for somebody who may have actually a clot in a lung, ranges anywhere between 3.5 to 60.1 or something. So according to this would be worst case scenario. This is the point of indifference. And this benefit the harms of in this particular case of blood thinners, meaning benefit with the red clot, harms patients could unnecessarily bleed, correspond to probability of that particular patient having disease 21% or so. So in other words, if you believe that probability is above 21%, you should act. Is below, you shouldn't act. So you can see here that if benefit harms is increasing, your probability falls. It's falling dramatically. And if it's a 60, as some estimate of systematic review suggests, then you should be certain about what? 1 or 2, below 2% that you should act. In other words, you rationally justify to give a treatment to majority of patients who probably don't have this diagnosis. And that's driven by best expected utility rationality principles. So the paradox is here that expected utility, normative theory, widely accepted as gold standard in medicine, will predictably lead to further increase and, you would say, waste in the use of diagnostic and treatment interventions. And so if you then apply, for example, expected utility to the example in this case is whether the patient should really be given the drugs against tuberculosis. So the patient presents to you as a cough, you suspect it has tuberculosis, and the threshold for that action is only 2.7%. So that means if you suspect this patient has a 3% or above the tuberculosis, give him this treatment for 6 or 9 months. When doctors were actually asked whether they will give this treatment, majority of them, at this probability, majority of them wouldn't. Majority of them would give it the probability 60 or 70%. And one of the reasons because they would regret decision of unnecessarily treating this patient for so long. So brings me now to really the role of emotions in defining rationality. And one of the key emotions is regret. And rationality, according to regret theory, rationality aims to regulate regret. Rational decision-making is associated with regret-averse decision processes. Which brings me now to the principle of number 3. I think everybody is probably aware of these dual processing theories, according to that human cognition decision-making works on so-called type 1 or system 1, type 2 processes, widely popularized by Daniel Kahneman. And according to this, our reasoning processes are based on this old mind, affect-based, intuitive, fast and resource frugal, and type 2 analytical, logical, thoughtful, so-called new mind processes. The key here is that rationality then would really have to really take into account both of these, and one way to do this would be to use the processes as a regret, which seems to serve as a link between type 1 and 2 processes being in cognitive emotion, allowing counterfactual processes. And so if you then reformulate that threshold model from dual processing point of view, then here's what you get, actually. You still, the solid line showed that expected utility prediction that you should act as according to benefit enhance, as per best evidence. But if your intuition or other process is telling you, look, in this particular, for example, let's say that you see the same patient, he presents with a potentially clot in the lung, but just about a week ago had this massive GI bleeding, and you don't have evidence in literature on those patients. They're never there. There's so many contextual details that you would have to adjust in situation on the ground. And therefore, that your intuition or type 1 processes start kicking in, and you would, in this particular case, adjust in such a way that threshold would go up. Or other way around, you think benefit so much outweigh risk, I don't even have to worry about that. You would adjust and your threshold go down. So fundamentally, we are arguing rational decision-making is determining at which threshold to act. Now, I'm not going to spend the time. This is a slide I made a long, long time ago, but I think it's fair to say we live in information. Thank you. We read an age of information explosion, but we need to, acknowledge elephant in the room. Our brain has a limited capacity for process and storage, and we need to work within those constraints. And so principle 4 would tell us that rationality should respect those environmental and human brain capacity constraint. And it does depend on the context, and the context should respect those epistemological, environmental, and the computational constraint I already mentioned. And famously, that's been developed by Norbert Simon, Nobel Prize, another psychologist who got the Nobel Prize for the theory of bounded rationality, which is basically extension of which is this adaptive ecological rationality that we need to work within a setting of a patient or an environment. The mechanism upon which bounded rationality or ecological rationality relies on its so-called satisfying process. Finding good enough solution could be more rational than going for best possible situation. Often this is actually employed in terms of heuristics, and heuristics, as you well know, is a strategy that ignores part of information with the goal of making decisions more quickly, frugally, and accurately than more complex models, and assume there must exist some, again, threshold at which obtaining more information or computation become detrimental and costly, and often is implemented via fast and frugal trees showed here. Those the fast and frugal trees, the simple decision trees with asking to answer yes or no, and this is a famous example. In a fast frugal tree for admission to CCU was superior than 50 variable multi-logistical model, and by ignoring information, fast and frugal trees actually are more robust, and one of the reasons why they're more robust than a statistical model, or could be more statistical model, because they avoid actually overfitting, which regression models are very susceptible to. It appears that mechanism that satisfying the mechanism that satisfies these works is through regulation of regret, and most recently, there was a concept of so-called robust satisfying has been proposed, which is similar to what we proposed a while ago, so-called acceptable regret. In other words, we can rationally accept some losses without feeling regret, and losses, as Russ, I think, alluded to, they will always have to occur because we always work under condition of uncertainty. So the key is to maximize confidence in good enough outcome, even if things go poorly, which would be then which would actually correspond to our rational thinking. And this is the model that we developed a while ago on acceptable regret. And this line here, acceptable regret, whatever you do below, you're behaving okay. Your choice is rational. But you can see here how I actually contradict expected utility in different ways. In some condition, it's, if you go by acceptable regret, you wouldn't treat. You would test, but according expected you wouldn't. In other conditions, basically, you would undertest, but according expected utility, you would overtest. So the point is here, depending which theory you use, you can see how can you go to overtesting or undertesting. Now, I think this is the fundamental. So Benjamin introduced concept of descriptive and normative theories. At the end of the day, rationality has to link both. We have to link rationality of is, which is what the descriptive theory deal with, and then it's derived from observation, derived what we're doing, and rationality of ought, what we ought to be doing, because everything about decision making. Now, it appears, and this is for me fascinating, that we are hungry for information. We really need reliable evidence to kind of understand the world around us. But at the same time, we also seems to be evolutionarily inclined to have a roles to act. So piece both of descriptive inclination or descriptive theory and normative in needs for ought seems to be actually ingrained in evolutionary determined in a human species. And so, for example, when you have a statement like faced with the knowledge that there are hungry children in Somalia, we easily naturally infer that we ought to donate to family relief charities. Or in medicine, certainly in my field, given the diagnosis of metastatic cancer is made, the patient ought to be treated. So you can see how this seems to be rational and easily to understand, but obviously not necessary if you actually act according to other theories. So Shira Elkheim then proposed actually really interesting what she calls the deontic introduction theory, and to show how actually the descriptive theory or rationality of is actually linked to rationality of ought. So according to this theory, this is how normative rules are generated. First, conditional relations, which would be part of what evidence-based medicine does, links causes with outcome. For example, if you smoke, you will likely get cancer. And from those outcomes, then we infer our values. And these values are then values or goals along cancer's undesirable outcome, which then results in transferring those values from goals to action. Smoking would be kind of bad. And we use this deontic operator, should, may, or must, whatever, to create that normative conclusion. You should not smoke. So when certain threshold for action is exceeded that we showed in the paper. So idea is here actually that rationality ultimately means integration of is and ought. So brings me back to the goals. The primary rationality is all about goals. What are the goals? Goals are subjective desire expressed as preferences. And people that, I have 5 minutes, I'll go very fast. So the people argued, look, whatever the principles, processes you use to achieve your goals, that's rational. If you need to use normative expected utility, use that. If you use intuition, affect, regret, use that. And from David Hume to Norbert Simon, people that has been argued, reasons are instrumental. This is guns to hire. They're in the service of our goals. What matters is our emotions and our and our passions. So, because as Evans nicely put it, there can be no rationality without emotions. So rationality then would require taking account both analytical, affect-based reasoning. The problem then becomes, and certainly we see that increasingly in medicine, what to do when the goals conflict. We said goals in medicine are simple, to achieve better health, but that's not always possible. And certainly in the time of our limited resources, we have to ask at what cost. For example, in the United States, when they calculate implementation of laws, they assume that human life value $10 million. So is this how to deal with that? And certainly, what are the goals of at the end of the life? That's not, death is certainly worse than health. And yes, many of us accept actually peacefully and rationally the demise. So again, coming back to Aristotle, of no deathbed regrets. So that the heart of the problem, then integration, obviously, of ethics. That's a link to the rationality, and then obviously all three big branches of ethics: utilitarian, duty-bound, and right-based, actually have a major role to play. I'm going just to go very quickly to this is the last slide. So I think Russ nicely put all our decisions are made under uncertainty. Uncertainty eventually is fundamentally irreducible. We cannot eliminate uncertainty in medicine. As a result, errors are inevitable. Because of errors are inevitable, there are usually two types of errors: false negative, false positive. And they cannot be eliminated simultaneously. And as you're trying to decrease false negatives, that you may decrease what you may actually help individuals, but then you would but then you would affect society differently. On the other way around, if you're decreasing false positives, you're doing false negatives. So all our decisions affect different people different ways, and these inevitable errors will be famously then lead to unavoidable injustice. And therefore, there is this inverse relationship between underuse and overuse, and the key is where to find that rationality threshold I mentioned. So this is the concluding slide. There are many phases of rationality as we put in our paper. What's rational behavior under one rationality theory may be irrational under other theory. No one model of rationality can possibly fit all contexts. And context is a paramount. I think this already alluded to. In context-poor situations, such as a policy decision-making, normative theory, meaning expected utility, evidence-based medicine, may be the best way to go. In context-rich circumstances, such as Ms. Scott, that theory that are based on understanding how human cognition architecture operates to minimize regret, perhaps would be the way to go. Which and I think I'll stop it here. Hopefully I did it in 30 seconds or minutes rather. Okay, thank you. I don't know if we have a time for a question. Yes? Good, thank you. Happy to answer any questions. Yeah, please.
I wonder about rationality. How to deal if there is a tension between the rationality of society or the healthcare system and the rationality of the patient. So that, say, in a society, in one case, society can put the maximum utility on a good life, and so can be rational to let the patient go with respect to that, but the patient instead wants to live no matter what. Or vice versa. Some other societies, the maximum expected utility is put on life without qualifications, but the patient instead would like to die because his or her maximum utility is in a good life. So how do you see the tension between different contexts of utilities and how rational, who is the rational subject in this case?
Yeah. I mean, unfortunately, as I said, I have to rush with this, and I actually put in this slide, that's heart of rationality a problem. We really don't have a kind of a off-the-shelf solution to that. And Keith Stanovich, which is at the University of Toronto, which is probably the best guy to give a talk on rationality, actually, he and I didn't really spend much time on this, he talks about integrating our goals, the key of rationality to try to achieve coherent integration of goals. And he talked about a hierarchy of goals, as you mentioned, society, individual, genes, behavior, all of these things. And both emotion, and I think we can't do with expected utility anymore. I think emotion, I hope I convince you that emotions have to play the role, even if we violate expected utility theory. And according to him, and again, coming back to John Rawls about, again, deliberation and reflectiveness, so asking reflectively about our appropriateness, our emotional reaction to decision may be key. To trick maybe to value formal principle of rationality, but not to take them seriously. And that's, you gotta make this judgment, which we don't know how to formulate or not. But I don't think we have a, technical solution to that. It may not be possible to develop technical solution outside of this general principle of integrating goals of individuals with societies.
That'll be the last question. Thank you very much.
Okay, thank you.